2014, and we are gathering today for a public meeting, open workshop to discuss county health insurance. And as we always do, we're going to begin with a prayer and pledge of allegiance. Starting our prayer. Dear Lord, we thank you for another precious day of life, and we just turn it over to you and ask that you be our leader, we be your follower, and we obey in every way. Show us through this meeting what your will is. Grant us the wisdom and knowledge and leadership to be able to make choices that potentially affect costs to the taxpayers and costs to employees, and help us to find the right mix. Thank you for the guidance and leadership of CAPS Insurance. We appreciate their work that they do for us. We ask that you bless that organization, bless this Commissioners Court, the employees of this county, and the taxpayers of this county as well. We just give you the praise. In Christ's name, amen.
Amen. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay, Steve, how do you want it? I don't have any opening statements, so I'll turn it over to you.
Well, what I thought I'd Chris to do is kind of work our way through the renewal package, but just generally speaking, things seem to be working along like they're supposed to. We're running a little hotter than we were last year, but still looking back, 2 or 3 years ago, still much better than what we were even doing. So, but overall, I think we're going pretty well. I think a lot of the claims issues in that transition period has settled down, and we're working through each one of those as they come along. But Tony, wouldn't you agree that that has very much settled down as far
Yeah, we
as?
really have not received nearly as many of the volume of phone calls. I think people understand the plan a little bit better. They're understanding, that UMR is a subsidiary of United Healthcare. We still may need to address some of that, as Mike and I were discussing a little bit earlier. But our volume of calls has definitely gone down. Christine, would you agree?
I still find the attitude of employees that perceive UMR as that insurance company in the sky, like Blue Cross Blue Shield, and they're the bad guys that deny or approve my claim. And I'm trying, whenever I talk to them, to help them to understand they're simply doing what we tell them to do. And we will always look into a situation that we have created that may not be fair, and we've addressed some of those. But nonetheless, it's not CAPS and UMR versus the county. It is the county telling CAPS and UMR what to do, and we're going to live and die by those decisions. And so occasionally a situation will come up that we'll have to address. But nonetheless, it's our plan, and that's a hard concept for people to understand, that UMR is simply, a check, not simply, that's not right. It's a check writer for us. It does what we tell them to do. And so, if you have a beef, blame it on the plan, blame it on the Commissioners Court until we can get it addressed.
Well, and there are two times, Brad. We're all UMR's operated by humans like everybody else, and they can make mistakes, and sometimes that's what that is. But we're finding that most of the time it's maybe a little misunderstanding about plan design or something like that, and some issues like some unanticipated benefit changes that we had that changed things, and then we kind of had to work through those. But it is very much settled down. We're always going to have sometimes we have misunderstandings or things that need to be addressed, and we want to address those. We want to take care of those, and can't always solve all of them, because if it's paid correctly, then that's just the way the plan is not set up. So,
Well, that's
anyway.
I've got one guy who had a colonoscopy in the hospital, San Luis, and I got to looking at
was probably Kobe's problem. As far as, the insurance not paid it or whatever. So he said that's what he thought it was. It might have been Kobe's problem because that is on our policy for health or wellness. So, but he's gonna go talk to him about that. So, try to get that straightened out.
And we have had a couple of claims issues where people have contacted us and received a bill from a provider in Greenville. Didn't you get that? And you got the same thing, right? That apparently the hospital sends all the lab work to this person. Is that what we figured out?
That's what my particular situation.
Yeah, and I know that I had another call from another elected official. But when I called UMR, they said, okay, they just need, this will be taken care of. They just need to ignore this bill. And it was, right? Yeah, exactly. So I called Stacy and then I called the person back. And so, and a lot of it is just, again, communication and just kind of working through those deals. Don't pay the bill too quickly. Make sure, let UMR have time to actually code it and pay it before you start, writing a check to somebody who bills you for something. Because this bill was all, it had to have been sent before they left the hospital.
I got really quick.
I was going to ask you in this particular situation, do you know, you may not know, but has the employee received an explanation of benefits with a hospital claim?
Well, that's what I asked her this morning. He had gotten a thing from UMR, and it said on there, this is not a bill, but he got an individual bill from the doctor and the hospital. So, and what like I told him, I said, it's probably just, they coded it wrong up there. Yes, it's wellness, but, there might be a slip of a key.
Well, it might be a mistake at all, they just need time to run through the system.
Right.
And be processed.
But I mean, and like anybody, you get you know it's wellness, but then you get a bill and you go, what is it?
Yeah.
I'm guilty of that too. So.
That's all right.
But
We'll work through each of those and, try to come to a good resolution on all those.
I'll tell you something that's caught me now 3 times. I get the UMR paperwork in the mail, comes to my house. Usually I'm assuming it's just, well, here's what the charges were, here's what we paid, but sometimes there's that little line down there, please call us, we have questions for you. And if you don't respond to that, nobody's getting paid, or it's gonna sit there in limbo, and then you're gonna get all these other bills, or because you failed to make that call. So we've got to be sure we educate the employees every time you get a piece of mail from UMR, read the fine print, see if there's action on your part that needs to be taken, because usually it's nothing more than entering a computer telephone call that, nope, I wasn't in a wreck, punch one.
Good.
Okay.
Take a run with it?
Sure. In your spiral document that I provided with you is the first 6 months of our claims data. And now that we're in our year and a half with Titus County, we'll compare that to the previous 6 months, which was last year. So if you'll move to the very first page, which is going to be page 2, it's going to show you what your average employee age and member age is. You're fairly consistent from the previous year to this year. Your dependent ratio is at 1 to 1.5, meaning for every employee, you got 1.5 family members. You did increase slightly for 2014 in your employees. Last year, this time we had 125 employees enrolled. You increased to 130. And with that increase, you do see generally an increase in your membership. So there was a couple of additional members that were added as well.
Chris, can I ask a quick question? That employee to dependent ratio, is that a ratio of actual dependents that are covered, or just the number of dependents that people have? I'm assuming those are the ones covered.
Correct. It is. So page 3 is now showing you a snapshot of your total claims so far this year. As Steve indicated, you're running a little warmer this year than you were last year. Now you got to also take into consideration in last year, generally the first couple of months when a new group comes on, you're not going to have as many claims that'll come to us as they will would run out of your previous carrier. So it's not going to be much higher. You know, you had $579,132 worth of medical bill claims in that first 6 months. Maybe that would have gone up to $600,000. But just knowing that there's a few months lag in the report. But you are running a little over $1 million in medical bill. Now, this is bill. This is before discounts, ineligible charges, and your deductibles and coinsurance. So your next line is $187,000 that is actually not covered benefits that were billed by the providers that are not covered under your medical plan. Then you have your discounts of $380,000 that's reducing your charges by seeing in-network providers. And I'll explain in a few pages back the discount further and give you what we're looking at so far. So then it makes your medical bill allowed amount for Titus County at $532,000. So this is where you, the county, and your enrolled members start incurring costs. Benefit design is deductibles, co-pays, co-insurance that your members pay out of their pocket. Then there's coordination of benefits, which is really dropped off, meaning that anyone who has other insurance, like a dependent or a child or a spouse that has other insurance, they would be primary on their plan because they're a secondary person covered. That really fell down a lot in the first 6 months. I mean, you only show $145,000 worth of claims. So to me, what that would mean is that your plan is very good and the dependents that are being covered may have dropped their other plan to come onto your plan. And because last year at this time, we had almost $3,300 worth of other insurance that paid primary versus UMR or Titus County paying the claim. So the county's responsibility of medical pay claims was $452,719. Your prescription drugs for the 6 months is running at $116,731. For a total paid of $569,450. Any questions on that part? What we do down below is we break this down into your average covered employees is 130, so we've broken that down into a per employee per month medical cost and a per employee per month pharmacy cost. And you'll see that you're running slightly higher than our normal book of business, our UMR book of business, but you've got some ongoing situations right now with some members. So that's probably the spike. That is the spike that's going on. And then your dependents, also 197 dependents and their average cost for medical and pharmacy.
Was that average net cost what we actually paid out?
Yes, that's at $569,450.
And you're comparing that to a comparable UMR policy?
No, it's our entire book of business. So it's not just comparable to your size and your industry, it's our entire book of business.
Would part of that be the fact that we've got a really nice plan compared to some of the other plans?
That and some ongoing claims. So those, yes, those two factors will play in why your average is slightly higher. And then we've broken down the, did you have a question?
Yeah, well, I was just going to say, when you look at your total paid claims, if you wanted a more accurate comparison there, you would take, Carl, the claims that you paid that were under your claims that were, were incurred prior to January 1 of the year we took over, and add that group of claims to this 291. So when we say you're running a little hotter, yes, you are, if you just look at these numbers here. But if you took the claims, what we would call runoff claims from the previous provider and added those into this mix, you're probably not that far off, where you were. Maybe running a little hotter.
Well, my cash, the total cash in the insurance fund, not counting the claims money, because that's gone once it's
Right.
there. Right now is at 383. It's at 383,000. That's what I kind of watch. If that number is, if that's going down, that means I'm using more claims than what I had compared to the year before. My money's down from the year before, and I'm putting the same amount of money in there from the county's participation and the employees' participation, and that number's going down. That means my claims are eating up my profit. It's still at 383. That's probably down a little bit. I'm going to have Christie pull up. I pull that number at the end of the month. We have Commissioners Court Monday, so I'll have all my bills paid for the
But
month.
you're constantly putting money into that and
Yes.
constantly taking it out.
Yes.
In other words,
Yes.
it's $750
Yes.
per employee going in there.
That's right. And
Have you seen it trending down?
It's been holding pretty steady. I was a little surprised that that number's that high because I haven't seen that much coming out of my money. So that kind of tells me what you say. It kind of confirms what you're saying. It may be down a little bit. I'd have to pull July, the end of July from last year to see what my cash and the insurance fund look like. I'll do that Monday after we run the claims and also for the last court date. But I think I had a little more than 383 in there to start the year, so it is down a little bit.
Yeah, it'll be helpful once we, the plan kind of matures a little bit. And
Yeah.
it'll mean more one year to the next, it'll tell you more. So, but anyway.
Any other questions on this page? All right. Page 4, this is showing you where your claims dollars are falling in ranges. So in 2013, for the first 6 months, your claim dollars averaged between the $1,000 up to the $50,000 category. And as you can see, for 2014, we do have some claims that have now spiked from the $25,000 up to the $100,000 category. Any questions?
So we've got one patient there at 45 claims, 217 services. Am I reading that right?
That was for last year, yes.
Okay, that was last year.
But in this year, you've got one patient that's got 41 claims and another one patient that's got 53 claims. That's correct?
342 services.
Well, that can be a lot of things. It can be on your pharmacy, you can be your,
20 lives on one day.
Wow.
right, that is account for every single charge that's on a claim. It doesn't seem excessive,
But that does tell you, if you look at 14, you've got basically 5 people that are by far the majority of that number. It's 38,000 and 59,000 and 91,000.
correct.
But Chris, is that counting for
Yes, those are the claims that are, for the folks that are laser under stop loss. Page 5, this is showing you your high-cost claimants. So it's showing you a comparison of last year to this year. The number of patients, as Carl just pointed out, we went from 1 to 5 now. So your percentage of high-cost claimants is spiked up to 3.7%. And the average cost of the per member per month cost for that high-cost claimant is now at about 46.3% of your overall claims dollars being spent. And then the average charges of these claimants. And down below, you're going to see the high-cost claimant detail. All of these members are active members. Member 5, those claims are pretty much done. Those have been incurred and now they're over with. But your top 2 high-cost claimants, they're still ongoing.
Okay, so the last 2 columns equal all current total paid.
Current total paid, yes, and they'll match, and then you'll see they coordinate from on page 4 of the dollars that were spent. So that 91,064 That's your claimant from page 4 that was in the side 75 to 200,000 range.
Can you tell us, or would it be beneficial to tell us of these 5, which 2 are the lasers? I think I know, but,
Well, the first one isn't.
yeah, I think it's 2 and 4.
It is. It is.
Now, by lasers, that just means
They're,
we
They
have
were
to pay.
identified up front, and we're not covering these.
That's right.
they're not under your stop loss $50,000 level.
Right.
They have their own individual specific level. One's at 125,000 and the other one is at 200.
It was even Tuesday,
Yeah.
But at least, I mean, it's high, but at least they do have a place where to stop.
Yeah, exactly. There's a cap on them,
And
but
that's an annual deal.
yes.
No, we have not hit it.
No, they haven't.
And number 2 is the one that's at what, the one, it's the lower amount,
Yes.
Yeah.
Yeah,
which is actually the highest cost claimant at this point.
right.
Well, the highest one's number 1.
Right, well, I mean, of the 2 lasers.
Yeah.
And the number 1 claimant has been using some services that have been out of network. So there's also a reason for those higher dollars. There's some services that have been performed with out-of-network facilities and providers.
How much penalty have they paid as a result of that?
Well, they're paying the out-of-network benefits, so the higher deductible and the lower co-insurance,
But
there's
the
no
max,
expense.
but the maximum on that for them
County's
is
getting
$6,000.
51.
Right, exactly. So, but the county pays more of that as
The
well.
maximum they can pay on the out-of-network is $6,000 per person under our provision, so that's the most they can pay.
It wasn't a huge amount. We'll get over there in a minute and talk about in-network, out-of-network.
Right.
It's in the discount, so.
Exactly. Any other questions on page 5?
Just in an effort not to get off of where we are right at the moment, just chasing rabbit, but were any of these high claims retirees?
No, they're all active
All active?
employees.
Okay. Oh, okay. That's good. Okay.
But you do see that one is
Over
65.
65.
Yeah.
Oh, their status is active on days. When they say they're active.
Page 6 is breaking down these dollars, the entire cost of your dollars, into the type of categories that you're seeing. So you've got your inpatient, your outpatient, your physician charges, and your ancillary, which can include your durable medical equipment, some pharmacy charges that are actually covered and allowed under your medical plan, and anesthesia charges such as that, not anesthesia, I'm sorry. Prosthetics and durable medical equipment. So your inpatient claims did spike up. So correlating to these high claimants on the previous page, these top 3 people have had some inpatient stays. And your outpatient, again, a couple of the folks on the high cost claimant list were outpatient. And then physician charges, whenever you're seeing a doctor, whether it's a doctor's visit, your outpatient, or your inpatient, those are all encompassed under the physician charges. Any questions? Page 7 is now breaking it down even further as to the top service categories that you're incurring. And that first box is showing you where your emergency visits are. And emergency visits per 1,000, you almost doubled from the previous 6 months of last year at 326 visits. We definitely want to, that's another piece that we can talk about, and I've got some recommendations for you all today about in lieu of emergency. Office visits, lab, and radiology, these are always good things that people are going office visits and having the lab and x-rays done in network providers, because that really does keep the cost down. Having the lab and x-rays performed in a freestanding facility or at the doctor's office versus going to the hospital to the outpatient setting is a cost-saving measure. And then your top categories, you're in hospital, inpatient hospital, And then we skip over radiology and go down to surgical facilities. And I made a note because if you go down to special services and treatments, that is showing at $29,000 as well. Those are tied together because you need, the surgeries and the surgical or special services and treatment. There's a line down here that's where your anesthesiologist and your supply charges are come together.
The surgery facility would be non-hospital, like a
Right.
specialty center?
Or a freestanding surgical center. I'm not sure how many are out in this area, but in the Dallas-Fort Worth area, they are popping up left and right. The unfortunate thing is that these centers that are coming on nowadays are not contracted, and they're physician-owned. So the doctors in network, but they have a vested interest in these standalone surgery centers, and they're referring patients there. And it's still even cheaper to go to outpatient hospital in an in-network hospital setting. And it's very confusing. I mean, I do this every day, but to the person that's just insured, they're listening to the doctor.
They're going to their doctor who's in
Yes.
that work, and then he's sending them to his
Yes.
surgery center,
Yeah.
which is not in that
Right.
work.
So there are just lots and lots of communication that are going on with United Healthcare Networks. We've got several charges of folks, different departments. We've siloed our network department now that we're out communicating with doctors that are coming and going together and getting these surgery centers. We're having communications with them about, hey, you're in network, get your surgery center in network. We don't mind you referring the patients, but partner with us, get in network. Another one is a topic they call lab leakage, is for providers still referring out-of-network labs over to high-cost labs. So there's a campaign going on with that. So
But what incentive is there for the doctor to take his out-of-network surgery center and put it in your network?
No.
Where he's going to be limited?
very little. We are getting it done because of peer pressure. What's helping us is customers whose employees have been impacted by this are coming back to that doctor and speaking up. So it's starting to come
Say,
around.
hey, next time I can't
Yes,
use you because
exactly.
your surgery is.
Yep.
I know that we have another group that uses, and is the United Healthcare cost comparison tool, really similar to UMR's cost comparison.
It is exact, and I have information about it.
And that is something that I really think we need to emphasize, because I have a situation, it's another group that's insured with United Healthcare, and he was actually going to pay out of his pocket for an MRI to be done, because he thought he has a $5,000 deductible, he thought it would be cheaper for him to just pay the cash price. When he was there, they said, oh, no, all you really need to do is pay $374. And he was like, $374? And so he came back to the office and he asked the office person, who asked me, is that right? And so we actually went online to the cost comparison tool, plugged in all the facilities in, it was in Texarkana, in the Texarkana area, and that exact number popped up as being out of pocket. You plug it in with your information, with what you have met in claims so far, what you've met in your deductible, and it actually tells you what the allowable amount is for that provider. And you know before you have that thing done, how much you're gonna pay, and it is right on. And that is something that these people need to know before, but of course, y'all's plan is really rich, a lot richer than obviously the $5,000 deductible plan. So is there incentive to do that? I don't know.
But I got brochures and information to present to you all today about it, and like Tony said, it's logging in and putting in specific information. I need to have an MRI, or I need to go have surgery. You're going to put in what doctors you want to use, what hospitals you want to use, and then it's going to bring up the most cost-effective ones first. If that doctor happens to be the most cost-effective, it'll be on the first line. And then it will give you specific dollar amounts that it should cost you. These are not ranges. The old adage of the usual and customary is gone away. We are
When I
now
did this, it
moving.
was 374, 700 and something, 1,300 and something. I mean, if you're looking at that, why in the world would you even think about something that was more expensive?
This is available on the internet.
Through, it's
You just go to
now-
your website.
You would have to log in with your member login, and then you punch in cost comparison tool, and it will pull up. This is very much like what I talked to y'all about last year with the Compass plan. Now, UMR has just taken it and done their own version of it, but it is very effective and very enlightening.
I'm passing around the brochure around now.
Can we get a handle on that and make employees use that?
You could do that as a regular deduction, because you got to make it where they have incentive to do it. They have, just like these doctors are put their, that's why they set up those surgery centers, is because they're not.
Right. But when a member uses this tool and they plug in that surgery center, and then they see that there's other surgery centers that are least, that cost them less money, then that's what's waking the folks up. This is available now. We rolled this out just last month. It's actually, if anybody's been on our website recently, we revamped, redesigned our website, and it's what we have, what we call tiles. So instead of trying to figure out which line means what, we made what we call little white boxes underneath your benefit information. And all you have to do is click on where it says My HCE. And it's very user-friendly as also. You plug in, yes, that's it.
Help here, here.
We have to log in under you specific, under your, because it's not just, it's your specific login.
Yeah, it shows what you've never
Because
done.
of your deductible, your out-of-pocket, it's going to give you your specific
What's in your
information.
plan, who you work for, what your plan.
Yes, yes.
But as for you, not just the overall.
Right. So we definitely want to get the word out to your employees. I can send this electronically, whatever ways we think it's right to educate the employees and their dependents on this, let me know, let Tony and Steve know. We'll work together to find the best communication piece we can do.
And I'm just gonna go ahead and say this now. I've got 2 groups this year, and they're not UMR groups. One is a little bit of carriers, but they're trying to tie in a similar plan like this with knowledge with their people, right? And one of the groups is saying, you've got to log in to the website and do this, and then you've got to take the health assessment, because there's another thing that's on here that's a health assessment. And if you do that, one group is actually, there's a difference in the premium than what you pay than if you don't. The other group is getting like a prize. They do a drawing every quarter of all the people that have done it. Because until you get your people to know, A, that this is available, and then B, to actually do those health assessments, you don't know who's out there sitting in there. It's a ticking time bomb. They may not be going to the doctor. They may not be doing anything, but if you take the health assessment, it will identify some of those risks. And that's kind of the first phase of the wellness program, which I know Chris is going to talk about that a little bit more too.
Nicole, point to using this tool is at the end, when you plug in there all your information, you get your final result, you can actually print that out. So that employee could take that back to their doctor and say, you want me to use this surgery center, but look, it's cheaper if I go here. And it's starting to get engagement, conversations with the patient to their doctor. It's a tool that we firmly believe in, and we'll do whatever we
All
can.
our employees know their
We tried to,
information to log in, because I don't think I know mine.
well, we put it, let me see if we,
Where do you
You have to set up.
we put it right here.
When you go to UMR and set
That had a lot of
that,
businesses that probably changed
you put
over.
your own password and all that stuff.
There's going to be a certain number of employees. I mean,
Just tell them,
they got 100% preventive care, but they're not going to go receiving preventive service. That's all they're doing.
oh, well, so share of
Would be
or somebody that says, hey, let me tell you what
That won't get around here.
We put this in last year,
They-
but all the
they
2
have
groups I
knowledge.
talked about, we actually do we did the step-by-step login, we put it in this book.
I'm about halfway with
You know,
this.
some people are still not gonna do it.
I'm afraid I
I
have
mean, you know,
but
we've had some people in the office.
same page as with you.
Here's the deal too. These people, the computer systems are getting so smart, they know if you are logging in on somebody that's not you. And they're gonna have to do it at their own. that make sense? Yeah, I mean, you're gonna have to use it, try to, we log in, but log in on.
Put used parts on this and
So if
this.
somebody comes to our office and just say, we help you do this and that in right here, they're gonna show me looking at mine, plus you looking at
They're not.
Let me make sure, because you wait to see their website. If you log in already as somebody else and you go in and you try to create a user, it knows that it lets you do it, because you are in the same thing.
I agree with you on this.
Yeah.
I don't know if we had time to do all
We
that.
don't. But I mean, if it
We can
takes-
tell, you know, if they want to come by, we can give them the brochures or whatever, and say, here's what you need
So
to
we
do.
need another department to do that, or another employee.
And, you know, referring to our customer service team, they have time
Yeah.
to walk you through the steps, say.
But if you give them, if you give them that deal you're talking about, it walks through it.
It does.
Yes, it does. And, you know, we can incorporate that by HC in it too, which is the health, it's called a health cost estimator. And the reason this is mine in front of it, because as Tony and I said, it is specific to your information. So demoing it to the folks, I can do that. We have some demo tools. I would say they're not as easy to use as someone specific, so you could pull up and say, this shows that your deductible's been met, this shows that how much your co-insurance is, so it's very member specific.
Yeah, I think what you need to do is, you meet with them all anyway, I think you just need to emphasize to them, give them the handouts and say, opinion, this comes up, you do. But it's still got to be an incentive, I mean, the plan's got to be designed
Right.
to make them want to do that.
Right.
Because if your decision is, oh, I'm gonna have this done in network, this must be the best deal out there, it costs me nothing.
Yeah. Better or cost efficient. You go in and if you don't have a specific doctor, you ask it to check the doctor, you doctors, and you can put in.
There's still a zip code.
Yeah, pull in zip code.
Everybody in the zip code.
There's, you know, a few steps. You can go back and start over again and put in different information and pieces.
I've never done
And we
it
could-
on iPad, so I don't know, sometimes iPads are different than the computer.
Yeah, Paul asked, we can, after the meeting too,
Yeah.
you know, walk through that meeting too, so.
How many people are gonna truly shop services based on price?
That's the thing though, we'll shop services on price, everything else but our insurance. And that's what we got in healthcare.
Because it's not
Got a $5,000
I know.
If you have a $750 deductible, you're not gonna do it.
And the $2,800 in-network out-of-pocket maximum. Someone's gonna have a heart surgery,
And I also
knee
say
surgery,
this,
they know they're gonna go
anybody
above that.
fence, if you're sick, you want to go to the doctor you think can make you well.
And this tool is more for that planned type of surgery, that back surgery, that heart surgery. Big stuff that's gonna cost you a lot of money, that MRI, that CAT scan. You have the time to go in there and look this information up. And like Tony said, MRIs don't really cost thousands of dollars. There are facilities that we have in network that will cost you $300, $400. So it's a range.
That's not really for picking your, which oncology you want to go to, you know.
Well, you can find that on the network. Well, because it's, one, doctors and facilities are able to, we're always in negotiations and renegotiations. Everybody's contract doesn't renew at the very same time. Every month, we're renewing and negotiating contracts all over the place. So if I were to print something and burn 3 or 4 trees, it's gonna be outdated the minute I hand it to you. So using our website, which is updated daily, gives you the most accurate information. I wouldn't know what you specifically wanted. If you wanted to go to Mount Pleasant or if you wanted to go to Tyler, you know, you can put in your ranges and it would allow you to select it. That's why we're offering you that ability to, if you're doctors, and that was it. And we, we're very specific on that. This is allowing you your services, what you need. Okay. I mean, we have to go through this with you after this. Any other questions? Okay.
Page 8.
Page 8 is talking about your actual admissions, showing you per 1,000, that there were 61 admissions in the first 6 months, and the admit days per 1,000, and this is averaging, were 255 admits. Your length of stay was average to what you had last year, and it's actually below. So folks were getting in there and getting taken care of and being managed and getting out of the hospital. However, the cost of your admits, and this is partly due to some out-of-network facilities being used. So you can see why it's very cost advantageous to stay in network.
I want to clarify one thing. Remember, on these numbers that she's showing you here, like admissions per 1,000, it shows 61. That is a ratio, okay? And that ratio is designed to compare this year to last year on a year-to-year basis and compare it to UMR's norm, okay? That does not mean that you had 61 admissions. Okay, does not mean that you had 255 admit days. Okay, that is a ratio per 1,000.
For 1,000 employees?
Yes, I mean, it's just a ratio is all that
So
is.
you lower that down to our 130 employees, and it's,
Yeah, you
Yeah.
didn't have 61 admits.
Right, and it works the same way on the page before. You didn't have, like on the emergency room, for instance, you didn't have 388 admits, okay? That is simply a ratio to compare year over year into UMR's norm per 1,000, okay? So don't let that you didn't, like on your ER facility, you didn't have 388 people go to, 388 admits to the emergency room, okay? Because you only have $15,000 in emergency room charges, okay? So it's just, those are just ratios to show you how you compare year over year and to UMR's book as a whole. Okay? So don't, you look at those and you go, whoa, I had 255 people admitted in the hospital, and that's not the case. Okay? So it actually shows that you're running more, look on your admit days, all right? You're running more than what you did last year, but you're still under the UMR's norm. Okay, so you're not out of range according to their book, all of their groups combined based on those ratios, okay?
The inpatient utilization, now this dollar amount is the actual that was paid for your members at $142,000. And down below is showing you the services, and it would be broken down by category. So inpatient medical is the 23,000, and then this is a ratio of average cost per admission. So for medical inpatient was average $80,000, but your surgical average was around $23,793 of your admission cost. Sorry, 8,000 was last year and 23 this year. Page 9 is where we're showing you your network utilization and your network discounts. So members, and the top is utilization, and you're still at 98% of folks that are using in-network providers. And then your average discounts have dropped off slightly. It's down to 41. I don't expect that to go down much lower. It should be averaging out. But what has happened is, again, there's been some out-of-network utilization. So if you'll drop down to the bottom box, it says network, discount by network. Your United Healthcare Choice Plus network is your primary network, but we have those secondary, or what we call silent networks. So if a member does go out of network, we still try to achieve a discount for the savings for the plan and for the member. You had claims between the 92, the 14, and the 3,000. These are the silent network names. And I don't know if you've ever noticed, but on the back of your ID card, there's a network name at the very bottom. And I believe it's multi-plan. Those are your secondary or silent networks. If that doctor or that facility is contracted with those silent networks, any one of those, we'll get it repriced. We still pay the claim on the network, but the actual claim will be lowered by that discount amount. So we're trying to save, show some savings somewhere. But talking and keeping people in network is very important.
I'm following around on the bottom of page 9
Sure.
for this year.
Mhm.
Your total claims are 913.
Right?
The part that's not in your United Healthcare Choice Plus, those aren't big numbers. The biggest number is up there in the top line.
Right.
And it's almost double what it was last year. But the discount percentage there has gone down 8%.
Some of the facilities that are in network, their discounts aren't as great as some of the other areas that were used. And I was trying to remember a lot, last year, your utilization.
Because we're at the same percentage, it'd be another, $60,000 savings there.
There are some facilities that are being used that their discounts aren't as great. And some of the facilities, Titus Regional is one of them.
But they're in network.
In network, just their discounts aren't as good as maybe going over to, into Mount Pleasant, into Texarkana and using some of those facilities, or Tyler.
You're gonna find that your single hospital towns, the networks are, the discounts aren't as great because they don't have to.
Right.
Whereas Tyler, for instance, you got ETMC and Mother Francis competing for business, and so right.
Well, I guess what I'm getting at is, looking at that page, I don't see a lot of out-of-network number. I mean, the actual out-of-network number is only $9,000. That's not a lot different than last year. I'm reading that.
Right. Well, anything, Carl, the multi-plan, the First Health, and the TC3 plans, all of those are considered out-of-network.
So they're paying the out-of-network, even though it says network total, that's not in the network.
Right, those are those silent networks that we were able to capture a discount, but those plans still were paid under your out-of-network benefits.
They're just not shown as out of network.
Right.
But really, that is just because there was a network to run them through.
Okay,
They just
but
weren't
they're not in
included.
our, they're not in our.
They're not in the United Healthcare Network, they're the secondary networks that you all have.
But still, the vast majority of them are in our network. It's just the
No,
discounts down.
98.5% of your personnel is using in-network providers.
We just have a lot more claims this year.
Yeah.
And the people know the folks are gonna follow the multi-plan or anything, they don't know that. All they're showing is, they think they're going out of network.
No.
Or do they think they're going out of network?
Right. And we have them after the fact, when the claim comes in, what happens is it goes through this silo and says, is it United Healthcare? No. Okay, we've got multi-plan, we've got First Health, we've got TC3. Is this provider in any of those? Yes, it's in TC3. All right?
So then the employees are making an active choice to go out of network.
Yes.
Then even for $80,000.
Right.
Oh, no.
But I'm very pleased that 98.5% of your personnel are still trying to stay in network, and that's a very good percentage, it really is. You just have to keep that momentum going, make sure that doesn't drop. You never want that to drop. Set that threshold, let's keep it going.
Well, no, and always especially like everybody, that you can be positive and encourage them to do that following.
Right.
And they can't help themselves to do.
Yes, have them call us. Our customer service staff is more than happy to help them find in-network providers. And we'll email them a list. They'll give us the range, the zip code, the type of doctors, we can zero that down to a specialist. They need to see an orthopedic, and they say, we're willing to drive 50 miles from this zip code. We can do that, and and email that out. It's an electronic function, it's not hard. It's a great suggestion. Page 10 is now showing you by major diagnostic categories where your claims are falling. Probably not a surprise that musculoskeletal is your top one based on the county. You've got your road employees, you've got your firemen, you've got your sheriff's department. You know, they do a lot of heavy work and hard work with limbs, back, knees.
That's gonna be back surgery, for example.
Yes, yeah, anything orthopedic related. Your next category, dollar-wise, that's high is your digestive. And then what I like to always see is within your top 5 major diagnostic categories is your health status. That's your preventative. That's your folks that are out there getting those preventative services done. So they've done a good job this year in increasing how many patients have gone. And yes, there's been some higher dollar amounts, but preventative is always a good thing.
What would like cancer related?
Well, it can fall in different areas. You know, you could have like your liver and pancreas. Then you've got your female reproductive. Skin and breast, it can fall in any of those types of categories. It's not going to say cancer specific.
That'd be more a diagnosis report. It's a little bit like diagnosis, but not really.
Right. And then our last page, this page, unfortunately, this report runs the wellness category, the preventative screenings, on a rolling 12 months. So what I did was I added a few additional pages that are behind page 11 that are not put together, that are just slipped in there. And what I wanted to see was what did Titus County's 2013 true preventative look like? And then what you have on page 11 under the far right-hand column is a snapshot of a rolling 12 months. So for 2013, on the single page that I have in my hand, for 2013, your folks did a good job on the wellness. For example, your adult wellness visits there were 153 members that were eligible, 49 of them got the services. And I'm going to kind of flip you back and forth, but our norm, I don't know even norm on that category. So in comparison to the UMR's book of business, you're actually running slightly higher in most of the categories, which is great. I know in the meetings I've had with you all, you've always emphasized, go get that wellness done. It's 100% under the plan. Go take care of yourself. So it's showing that your members are listening to that and getting those services done. We can always improve on it, and we'll always make that a topic of discussion during the employee meeting. We just remind them to get out there and have those services rendered. Some of these services, though, you don't get every year. Your colorectal screenings. Those are something that's 1 every 5 years on people. So, and there's age ranges. If you'll look down at the bottom on the screening definitions for mammograms, they don't start till age 40. Now, your average age, if you remember when we were on page 2, is about 45. So you're going to have most of your people eligible for that. Your cervical cancer screenings, those are female tests. Annual exam, PSAs, generally don't start till age 50. Your colorectal screenings over age 50. So you've got part of your population that really isn't eligible for that. So don't think that because we're not high in these numbers that we're not doing the right thing. I don't know about you, but I don't know too many people that are run out and have those things every year. Even though they do put you to sleep. But you want to keep emphasizing the wellness. So I just wanted to show you in 2013 what your actual numbers were. Any questions? Was there, I've got some other things. I mean, I thought we could talk about plan design and what would y'all like to discuss now?
Yes, you've got some, recommendations on plans. And, when we first started this process, one of the things that we had talked about doing was, you know, if you wanted to lean the plan up a little bit, was do a little bit over a period of time rather than make a big adjustment. So, you know, your current little $750 deductible, you know, you want to look at what $1,000 deductible would do.
Before we go to that, I want to listen to the comment about
Claims, no.
claims or that.
Okay.
Yeah, well, however you want to do it, you want to do it now, you want to wait? Okay, okay.
Maybe that'll help us.
Okay, I'm going to generalize these so that we don't have protected health information out here, unless Mike, you just want to talk about yours since you're here, you want to give us permission. Okay, then we'll start with you. And why don't you just summarize it? Because in that way, because I've got a lot of paper and I don't want to read this, so.
My wife, and she gets blood work and cholesterol stuff, all that's checked every year. Well, and Dr. Williams is her doctor. Now, I truly think, you know, they just do not like this company for some reason. I really don't think it's going to do it, make it work right. So I tried to tell you
The Williams or
Dr. Williams, and anyway, they said, no, we got to send her to the hospital. Well, it was cheaper to do it at Dr. Williams' office and get the results of anyway. You get it done at the hospital, you have to go down, you got 2 visits instead of so basically, we've worked, I've been working with her on this and stuff, and we think, and they're gonna go back out there and talk with the lady that does all the paperwork and stuff. But,
Well, I suggested maybe that Chris and I could go and visit with the doctor's office. I mean, after all was said and done, I mean, I think everything was eventually processed correctly, where they were only charging you the copay. I think maybe the problem lied in the fact that possibly they didn't like what they were being reimbursed from UMR. Again, part of that provider relations, you know, equation. I mean, they signed up to be a provider and they've accepted certain amount of money. Now, I don't know whether or not they think that by sending you different places, they get more money. I don't know what the objective
Or they
is.
avoid doing a service that they feel they're providing a loss. Is that it?
I don't know. I don't want to speak for somebody that I don't
well,
know.
I know like,
Now, I'll tell you what Becky told me, Becky Merriweather told me, the reason they send them across the street, because they don't get paid as much as it costs them to do it in office, do the blood work. Because I've been going to Williams, and they do the blood work, but they send it across. They draw the blood and send it across the street. And she said they can't run it for what this plan pays.
It's not that they don't have the technical ability to do the
They can
job.
do it.
Well, I understand that.
They just say that they can't, she told me that they just couldn't do it. She said, we're not gonna do it, we're not
Let
making
somebody
it.
else do it for cheap.
And I think, we adjusted the plan last year to account for this, because I think there was so much of this happening that, because in the past, that would have been paid as an outpatient, would have gone to a deductible, and there was so much flack about it that would change the plan to pay just like it would be paid in that doctor's office. So that could account for some of the reasons why the lab work has gone up as far as the county's paying. It's impacted the county. I mean, you may be helping your providers, but the county's paying more money because it's not being paid the way it normally would be
In other
paid.
words, if you have blood work at the time of your office visit, you still just pay flat $25 copay, or you get.
Yeah, we changed it to be that.
Yeah.
It was,
You get the blood work included in that visit.
right, whereas in the.
And X-rays too.
Yeah, the way it was set up, it was initially set up as if you get it done in the doctor's office, then, it's gonna be paid under the doctor's copay. But if they send you somewhere else, then it's gonna do deductible income insurance. But we changed that because that was impacting so many of your folks. But now it's probably impacting the county a little bit.
Which we knew would do.
Yeah,
It's just a
exactly.
matter of pushing around costs is what it is. So.
But I mean, all of my stuff I think got rectified. It's just a matter of working through it, which is the pain for him, as I know it is. And
what was frustrating to me, I know they were trying to get it worked out, but it was like talking to a wall out there at one time. Dr. Williams stepped in and said, we'll take care of it. you don't pay, you might pay, but I would.
If you'd done it the way you originally set it up, how much would we cost, because I go to Meriwether too, so.
Well, I mean, it's just
How much more was it gonna cost
the person.
the person?
So, well, I mean, it's gonna vary from claim to claim. I mean, so if they charge $100, I mean, if you had an extra deductible, you're gonna pay it. You're gonna pay the discounted fee, whatever the hospital's discounted fee was, which the hospital doesn't have as big of a discount as the doctor, obviously. If we kind of talked about that as well.
What was frustrating me, not really, was 200 something go into the blood work, cholesterol, and stuff like this. On the cholesterol, it didn't show pay anything on the cholesterol test, so, you know. Oh, we just need to go back, and I told them, and I know Tony was out there, and she was talking to people, and she was in a nice kind of way trying to explain it to them, and I think they got a little upset. Not like the Williams or the nurses up there, I'm talking about people in the back. And there's two different people back there, but anyway, I went to them, and I talked to them, and I did it in a good and kind and considerate way, and I think everybody's trying to work to get it accomplished, but, I know when she went to the hospital, we had that copay over there, and the doctor, this was the year before last, and it was 300 something in the hospital, and there's 200 something in Dr. Williams, and you're sitting there and you're looking at this, and why aren't we doing it in Dr. Williams instead of over here, that they pay him less, just like cholesterol, and as far as I know, they didn't pay him that. I thought they were getting the UMR plan mixed up with our plan. And I think it's confusing. People are getting confused about it. They want to apply us to their regular insurance policy, and we're not the regular insurance policy. We're separate. And I don't know how to get that across to them, but we're two separate things.
Yes.
I think that's the problem.
It is, and we had that conversation with them before, and explaining that United Healthcare is just your network, and they're contracted, so what they, but they're contracted differently for each service. And the person that's submitting the bill may not know what their contracted allowed amount is. There is a written guarantee between the two parties. I've made notes to have both Dr. Williams and Dr. Merriweather contacted again by our network folks. And then I'm not opposed to, as Tony said, going out there and talking to the billing people and saying,
The thing they're getting confused is they're still saying, well, you're UMR here. No, we're county. And my thinking process is we need to do something where they can distinguish this from this.
well, we can. I mean, your ID card has the UMR name up here, but you have to have your network name so they.
Look at that UMR.
I know, but on the back of your claim, it tells them where to submit the claim. So that identifies where the funnel of where the claim should go. And United Healthcare has a different address than the UMR address. And so, yes, you're right, that some doctor's offices, they do try to say the same thing. We have processes in place that when a claim would be accidentally sent on the United Healthcare side, truly to that address, which is Atlanta, our UMR claims all go to our Salt Lake City office. We do have the ability to.
When y'all visit with, you need to let them, this is the
Yes.
This is the
Yes.
problem we're having.
That's not what they told me.
No, I mean, that may be kind of confusing at first, but they are just saying that they're not going to get paid enough.
Just for money, they're not.
Right.
Exactly what they're saying.
If they agree to accept that, they can't tell me no.
Right.
I'm gonna get nasty, I'm gonna say, listen, you either accept it or you don't. You don't cherry pick what pays you well and send me off to losers.
They do.
Let me ask you this way. If you were Blue Cross, let me use it for example, if you were regular insurance, Blue Cross Blue Shield, how does that work? If you go with Dr. Williams' office or Dr. Merriweather?
Contractually, I think they're similar. I mean,
So I mean, are they telling those people, are they sending it over to the hospital, or are they paying?
Well, maybe, I don't know, the reimbursement rate for Blue Cross might be a little different than UMR. I would expect it to be very similar, though, because if you look at UMR's, discounts and Blue Cross discounts if they're a percent, so I mean, they're,
So what you're
they're not
telling
gonna
me
make a
is,
difference there, so.
what you're telling me is that they're probably doing this with everybody. There's not any.
Probably.
They're doing the process.
That's kind of what Becky's, of course, I go to Williams, the lab back here is Becky
Yeah.
on there with it kind of runs that, and she's the one that told me that they just
You
put it
know,
on there.
I don't know if there's anything in the contract, that'd be, something, look at, where they require that provider to provide a service. Okay, but if they do provide it, they have to agree to do it for a certain rate. Now, I'd be surprised if there's anything that required them to do to perform a service,
Wouldn't think.
so.
I don't know.
I think they probably have every right contractually even to refuse. I mean, it's like you refuse, I'm not taking any judgment.
Yeah, I think.
Period. I'm not taking any patients, so they refuse to give folks service because they have all that they want to do.
It sounds like they're just pulling the plug there, sending it to no matter which.
We don't do any lab work, it says UMR.
Or Blue Cross
Or
Blue
Blue
Shield,
Cross, or whatever, they make
They're
something do it.
they're all pretty much run the same way. So they're running good.
They do draw it there.
They draw it.
They'll draw it
They
there.
send the file
They
across
send
the
it
street.
across the street.
So, and you go to Burley, he draws it, does his thing right there, and he gives you the results back immediately, so, it just depends on what they want to do, and that's, that's okay.
Here, we're gonna first have a conversation with them and say, well, why are you doing this?
Right.
They're gonna tell you, we don't make enough money to do it.
Yeah.
And so then what are we gonna do?
Well, then, I'll ask that question. I'll ask,
I mean, there-
what does you and Networks, how do you approach that situation? And what kind of conversation, what happens in that?
Do you pick and choose what you want to accept under this plan, even though you've agreed to take this, to accept the terms?
But see, it's not gonna,
Well, I think
you've already
they'll
fixed
agree
it according to your benefit design though, so, there's not gonna be incentive for your employees to do anything different. I mean, if they were getting charged more, then you say, well, go to another position.
In my case, didn't you have to pay us $25 at the hospital?
No.
I
We fix
don't-
that.
When they send mine over, I don't do it.
Yeah, I mean,
That's what I'm saying.
Change your plan design.
it's costing the county more money to do it that way.
Her.
The county, your plan.
The hospital charges more than the doctor would charge.
Yeah, it's probably not enough to spit at, to tell you the truth.
And it's pretty,
I
so,
mean, I don't know that it's
Several.
the way it was originally done was, that charge out of the hospital was going to be applied to the deductible. Okay, so now you're paying
Which we had
100%
that for
of
probably
it.
about 6 months. We changed it we changed it during this meeting last year.
Now, I don't know what kind of number that is, but it's probably not enough to have a heart attack.
Still, I can be crazy on these.
If we get out of here before noon, we'll try to run over there.
Absolutely.
He said they close at noon. Okay, we have 2 other claims issues, and I'll make them be generic so that we don't discuss names. But one is an employee that has called. Apparently, she's seeking treatment out of town at a cancer facility. And the first time she went there, she'd met her deductible, so she didn't have to pay anything, and did not realize that that facility was considered an outpatient clinic. That's the only place that she can receive this treatment. And so she's called us to basically say, why is this done this way? So we researched it and determined that the only way they can bill it is as an outpatient facility. And,
Which means what? She already there to go.
well, but she had not met it this year.
This year.
She had met it last year, so that's why it was all paid. She had not met her deductible this year, so when she goes back for that cancer checkup, it was,
Subject to deductible.
yeah, subject to deductible. So I'm not sure if there's anything that you want to do about that, because you would have to basically amend that type of claim to be allowed as an in-office
A $25 copay,
Right.
$750.
Right.
or I think the actual claim was in the neighborhood of like 150 or something like that.
But
Was it
subject
more?
to the
Okay, if you've got more information.
It's subject to the $750.
Yeah, exactly. But, she's doing what she's supposed to do. She's a cancer survivor. She's going back to the best cancer place that you could go, without saying where. And, I just said, well, let's discuss it in the commissioner's court meeting. So, you got the specific claim?
I thought I had the amount. Hold on.
Let me tell you, this may be different than everybody else, but if I've had cancer, if I've got cancer, and I've got insurance, I don't expect the insurance to pay for it. I mean, if it costs me $150, that's pretty cheap for me to have cancer, that's all.
And that may be wrong, I may be wrong on that.
Or even if it's $750,
Yeah.
that's an expensive disease, and I want to get it treated, and I'm gonna pay my part, and I know I'm gonna, I would
Maximum
expect
amount of
that I'd have to pay my total out of
What,
pocket.
couple $1,000?
$2,000-$3,000. I know that's an
It was
expensive.
more than $150. I don't have the actual dollar amount here. I can tell you, I do remember that it was more than $150 for that visit. I want to say it was ranged $400 to $500.
But it's not gonna be a situation where the doctor's gonna pay, it's gonna be a situation where the county's gonna pay instead.
Right.
They wanna pay,
Yeah.
they wanna pay $25, so let's pay the rest.
Correct, yeah, because that's, and actually, last year, I mean, she probably didn't even pay the $25 last year, because it was, her deductible hadn't met, so it was paid. So, that, I'm just bringing this up, because these
Yeah.
are the things that I couldn't fix, okay, between now and the last time we met. So, if that's, the consensus,
Well, that's their call,
Yeah.
it's just,
I mean, your option is, if you waive it for her, you waive it for everybody.
And it just opens up a can of worms. Yeah.
Okay.
Yeah.
Okay, and the other thing is probably gonna be, the other claim issue is probably gonna be on a similar lines. You've got an employee that has been prescribed a level of medication higher than what FDA has recommended.
Quantity.
Okay, the doctor prescribed more than the manufacturer's and FDA daily dosage recommendations. Albert Perez, who's our RX person, says if this is something the client would like to override, we can do with your authorization. But again, I mean, is it a thyroid medication, Chris? I believe it is. Okay.
And it was appealed. The doctor submitted the documentation for appeal as to
And-
why they were basically doubling the dosage. There's still not justification, and the appeal was reviewed by our clinical staff, which is our physician, and based on manufacturer's recommendation and the FDA, we still determined that that was not valid.
So she's paying for this out of her pocket, which she can well do. I mean, if the doctor write up the script, she can go get it filled. But she's doing so against the recommendations of the FDA.
does it go against her, does it go against her gut or anything?
Does it, no, it's just paid out of the, I mean, there's nothing, it's just out of
You just
pocket.
have to pay that.
Yeah,
Part of it would be paid under your your pharmacy plan, because up to the quantity limit, she can give under that copay. It's the extra dosage amount she's paying out of pocket.
which I don't have the amount of that. You know
No.
that, Christie? Was it like $150 or something like that?
It is the discounted rate. We're not charging, she's not being paid the full amount. She's being paid the discounted rate of the pharmacy drug that we have.
But
it's still.
again, if you change that for that person, then anybody else that's in that same boat, you'd be changing. I mean, she did do an appeal, and Optum looked at it again, and their board they've got doctors and pharmacists on their panel that look at the appeals, and, they're doing it for her benefit theoretically, I mean, because the manufacturer has suggested what is the dosage range.
Sure, we can overprove.
Right. Well, we wouldn't overrule it, you just have to pay for it. Yeah.
Something happened to this person.
Yeah.
Right?
Like, the doctor will be responsible.
See, I'm sitting on I'm on the health insurance side here now. Now, all of a sudden, I've jumped over here on the general liability, professional liability side, okay? And you approve the discharge, and you go along with the doctor, and you go against the FDA and the manufacturer's deal, and something happens to her, and the husband sues the doctor, and the doctor says, well, I can't pay for it. Guess what? Here you are, you're gonna be right in the middle of something else. And I'm not saying that I don't know one way or the other. I mean, but I can tell you, if you try to overrule, you go against something the FDA and the manufacturer said for somebody, and you approve to pay for it, and you potentially could be a party to the suit. So,
I don't say, me personally, I don't say
say leave it up to the professionals. And I'm not saying the doctor's not a professional, I'm just saying that it's outside of those, you know, the range.
I think in the past, we found some glitches in our plan that we corrected that were reasonable. From here on out, those are gonna get much fewer and farther between, but if we start tapering it every time we've got a little small leak.
I'll put it back with these folks and tell them what we discussed.
We're not proposing a plan change.
Right.
It appears that your plan is based on.
Okay. Not a problem. That's all I have.
Well, in the lines of cost efficiency, there's another service that I wanted to talk to you about that we could consider implementing from January at your renewal. It's called Teledoc, and it is a service where members can call a registered or an MD 24/7 that are available for more minor type services. This isn't for someone who needs to go have, you know, something related to, I guess maybe, let me scale it back and say that it's more around a cold, a sinus infection, allergies. That's what you would use the service for. You would, instead of having to leave work, leave your home, you could call a doctor. Talk to the doctor, give them your symptoms. That doctor can actually have a prescription sent to your pharmacy if you needed one, and you could go pick it up.
If they're comfortable making that call.
Yes. And again, these services are more limited, and they outline what the services are for. So the easiest one to describe is a sinus infection. You really need to have an antibiotic to make that go away. And they're very uncomfortable. They cause you headaches, face hurts. So you can call them and say, here's my symptoms. The doctor can say, yes, I believe that's a sinus infection. What pharmacy do you use? And call in that prescription and you can go get it. Now, the average copay is $40 for this service. Here's why I'm bringing this up is, what we're seeing a lot of the customers that we work with that have added this benefit is, they've actually either waived the copay to the employee, because they're gonna bill us for 100, we're only gonna pay 40. There's none of that. So you're not gonna have, and there's no lab work, and these types of services, there's not gonna be lab work involved. They've either waived that copay or made it lower than what your plan's copay is to incentivize your members to use that service. Again, it's for not having to leave work or not having to leave their home in the evenings. It is very confidential. They do have to register online first and put in information so that the doctor, when they call them, knows who they are. There is an administrative fee of $1.50 PEPM.
Which is the member pay?
No, the administration fee is paid by the county. But the office visit fee, we'd have to discuss how you want that. You could set that anywhere from $5, 0, 5, 10, 15, 20, or have them pay the full amount, which the full amount is higher than your office visit copay, so it really would defeat the purpose of having this Teledoc service. But I just wanted to mention it. It's something that is available that we can add to your plan. It's fairly new for UMR, so I don't have any kind of data to provide to you other than my customers that have rolled it out so far. Their employees have given very positive feedback so that they call from their desk at work.
Obviously, like David, I think too, we had a doctor question to put a new line across the new road 4,000, because that's weekends and stuff like this. And they've got, I'm not sure what kind of line they're trying to, suddenly, just trying to put some kind of line in there. But anyway, you got that worked out, but you're going to start seeing some things.
Yeah. Doctors are looking for more ways to bring in more revenue. This is one of those this is perfect for nights and weekends. Keep them out of the emergency room, keep them out of the urgent care. The urgent care is a less costly center, but you still have some wait time. This is calling your doctor, and most pharmacies are open, 7 days a week. So that they call the doctor Saturday night, that doctor can call in that prescription Sunday morning when they open, and they can go get it the next day.
Well, now, this isn't calling your doctor.
No, you're gonna get a doctor, you don't know where you're gonna get a doctor from. Yeah.
But it is a licensed doctor.
Right.
It is not a fly-by-night physician. It is-
And I'm gonna tell you, Teladoc has been around forever.
No.
Yeah. You,
Yeah.
what the heck are you doing?
Yeah, Teledoc's been around for years and years and years, and other carriers use it. We actually can sell Teledoc on a standalone basis to customers that have nothing, and we have done that before.
Well,
It will help you keep
Bill
people
first
on.
started promoting this, when they knew they were about to lose it. This was one of the big topics when I went to Health First seminar in February. I like this, it'll take some getting used to, but
Well, I'll give you an example. I was going on vacation last summer, and I had one of these symptoms. I had one of these things. Yeah, and I went to the urgent care center in Atlanta, because I live in Linden, at 7 o'clock at night. I'm on not as rich a plan as the county is. So, sorry. So, I have a 5,000 HSA, which I pay my, but it cost me $113 just to go in. I knew I needed a prescription, write me a prescription. I ran across the street to Walmart, got it filled, and had a horrible vacation, okay? If I could have picked up the phone and gotten that script, that would have just been even better.
Chris, what's the monthly charge?
It's $1.50.
200 bucks a month to it, something like that, to have this.
Yeah.
$200.
Which could be one office visit. By the time you pay for an office visit or whatever.
Well, if you've got your own position, you're not gonna use this, but you would use it if you're out of town.
Well, or, I mean, my physician didn't pick up the phone at 7 o'clock on Friday night.
Well, the other deal is, a lot of times, they're not gonna do a prescription unless you come see them.
Right.
Of course, you're still gonna incur an office visit. I mean, you're gonna be paying the Teladoc, right?
Yes.
And now how do you
Whatever
get
the
a copay?
county
Well, the
decides.
county.
Okay, so we say a $15
fee. So the county either can pay the whole $40 or they can split the cost with the member and have the member have to pay $10 or $15, $20.
Okay, so let's say it's got a $15 copay.
Yeah.
I call it Teladoc, or they want my credit card to pay
Yes.
for it. Okay, so
Yeah.
they would pay for that with a credit card, their copay, $15 or whatever it is, or 10 or whatever you would pick, and then the county would pay the difference between the $40 charge and the
Right.
copay.
So we'll be paying $200 a month plus.
Plus the
Plus
difference, yeah.
whatever that office.
But you'd probably be paying more than that for the office visit anyway, when they finally got to where they can go to the doctor. So.
It does not have to have a decision now. I didn't expect one. I wanted to talk about it now. I have asked my underwriter to price it in your renewal when I get that. So you'll see that line item in there. I'll make sure to point that out and show you that average annual cost. Then we can, if you're wanting to go down that path, we'll discuss the setup process, making sure we communicate it to the employees and what you want to do on the office visit copay.
Let me ask you this question, I ask you this every year, and now I talk about it a little bit. Are you still comfortable that us being self-insured is better for the county than going to a?
Fully insured deal. Yeah, I mean, unless something changes. I mean, the only thing that makes me uncomfortable about this whole deal, okay, is I would prefer to see your retirees on some fully insured deal, okay?
We talked about
Generally
that,
speaking,
we'll talk about that.
historically, retirees cause self-funded groups a lot of trouble. It causes groups trouble anyway, retirees. And there's a way to handle that and not, the retirees not losing any coverage, the county's
Still
still
getting
pay
coverage,
for
but
it,
it
you
just will
know.
be on a different plan.
That's right.
Buy Blue Cross Blue Shield plan for them.
That's correct. So,
Matches this, I think that makes sense.
Okay.
Am I the only one worried about a 95% increase in claims?
No.
I haven't heard one comment about it.
Oh, yeah.
well, one thing too, Katie, remember we moved, it's not 95%. You have to see what you're doing. Right,
So
right.
when you do your renewal illustration.
It will be much closer
You will put
to,
in the run out or the run in or give us some.
we can't, yeah.
Even
Yeah,
if you
sure.
mature off the first year, it's still a 43% rating.
It's, yes, ma'am. Yeah.
And it's basically 5 people.
5 folks, yeah.
Not if you look at these monthly claims dollars or not.
Well, the increase on the 5 people that were the most expensive was between this year and last year was $220,000.
And you could have 3 more expensive next year. That's not really.
You could. Yes, you could.
And your point is that's a justification for going to a non-self-funded plan?
No, I just wanted you to, since no one had indicated anything about the 95,
Yeah.
since you were discussing whether or not you would go to full insurance or stay self-funded, you got a bigger problem at this meeting renewal.
Okay, so what's your suggestion? I mean, yeah, we see the problem, and you see the problem, what's your?
The only thing you can do is having a fully insured company quoted. That will give you a justification for your renewal.
But either way, correct me if I'm wrong, if you continue to see, whether you're self-funded or whether you're not self-funded, the worse your claims are, the more money you spend. I mean, Blue Cross isn't going to continue to eat losses year after year if your claims are getting out of hand. And where am I wrong in the assumption that I'm better off self-funded because there's no middleman? I mean, I'm paying those actual costs. Whereas if Blue Cross sees us getting older and older as an average age, and claims are getting higher and higher, those premiums are going to keep getting higher and higher. They're not just going to say, oh, don't worry, we'll take care of it.
I mean, they're gonna underwrite you. I mean, you're not, your size group, you're not totally valid as far as your claims goes. That's, and that's part of the equation too. But, I mean, if you were a 500-man group, then, they'd underwrite you to, a 85% loss ratio or 80 or whatever that number is, and that's the premium you'd be paying. When you're self-funded, when you have good years, you have the opportunity to, leave some of that in the bank. If you have a bad year, it just depends on what kind of, what makes it a bad year. You're protected for the one big hit. You're protected from an aggregate standpoint of having a whole bunch of little claims that fall underneath your specific that add up to a big, huge number. You're protected on both of those deals. But, might you, if you just had a horrible, horrible year, you had, 4 or 5 people that maxed out on their specific, and when you hit your, aggregate stop loss number, would that be worse than what you could have purchased for that same year in a fully insured? Probably.
Yeah.
Probably.
Yeah. When you
Yeah.
zero in on it like
Yeah.
that. And then the next year you could have a good year.
Right.
Say,
And, yeah, and as far as what Kay's talking about, I mean, it's no problem asking for a couple of fully insured quotes to see how those numbers turn out. Yeah, we have done that before, sure. Well, we did it when we took over, when we moved the group, we had fully insured quotes. So.
I'm going to give you an example.
Stop loss carrier will give you the credibility, so you'll know how believable this year is. And I don't think it'll give you much credibility.
I've had 2 groups renew in the past month. Both of them have a voucher same size. Both of them were fully insured. One of them was on a plan that was not compliant with the Affordable Care Act. They were running a 55% loss ratio, which would cost them, just to get them compliant to the Affordable Care Act, cost them 29 points. Yes, sir. Yes, sir. Yes, sir. Plus, they're subject to all the fees and taxes that you're not subject to being a self-funded plan.
Now, speaking, good segue. I pulled our healthcare reform checklist to kind of take a look at what you will be required to do for the upcoming 2015 plan year. And I have some good news on that. The only thing you really are going to be required to do is, I've got to still finish up looking at all the benefits, make sure that your essential health benefits, what the Affordable Health Care Act says and deems as essential health benefits, office visits, inpatient, outpatient, wellness. There are some of your benefits that may have to have some the dollar maximums removed, but we can replace those dollar maximums with a visit limit. I'll have all of that information detailed for Tony and Steve. But when you're looking at plan designs, the one thing you have to keep in mind for this coming year is your maximum out-of-pocket cost. You're well below what the law says you can have. The next year, you can have a member pay up to $6,600 as an individual and $13,200 as a family on out-of-pocket in-network costs.
We're at 2,800 and 6,800.
Right. Right. So you've got a lot. Now, you've got to also remember, you've got to now consider pharmacy out-of-pocket costs. That has to be combined. So we'll have to do an analysis of what your out-of-pocket cost looks like for a member on the pharmacy side and have to keep that in mind when you're looking at increasing any of your medical out-of-pocket costs.
They have to be combined now.
Yes. Starting in January, they'll have to be combined.
But if they're on
You're
generic
not-
drugs or something, that's only $5 copay, so it's.
Right, so you've got a lot of room. Your co-pays, your out-of-pocket, you have a lot of room if you choose to do that. I'm sure, I'm saying, is I was going to say, I'm sure you're probably not wanting to go to the maximum right away, but that's
It's kind of like what Steve said earlier, the best way to do this is a little bit every year, but I think you need to do it every year. That's y'all's call, but I do think you need to tweak it every year.
I got one question. Lady down asked me to ask you. Over to Pittsburgh facility, East Texas Medical in Pittsburgh, she said they pay more to that hospital than they do to this hospital out here. Is that, and I don't know that to be a fact. She just asked me to ask that question. Why you were paying more to that hospital than this hospital?
And this hospital being Titus Regional,
Type 3.
I can't answer that. That's done by the network folks and negotiations. You know, the contracted amount that they are willing to accept, and we negotiated that both parties agreed to. Titus Regional agreed to those rates, and then East Texas Pittsburgh agreed to those
And
rates.
this is that Colin Hellcat. Get that.
Pittsburgh is the network?
Yes, it is.
But now AT&T Tyler, not.
No.
No.
East Texas now is not.
Tyler's the only one that's not in. They're still holding their ground. All the
All their
outliers.
subs are just.
Right.
What are y'all ready to talk about? What you will do?
Yeah, unless you
I have nothing else.
you have no other topics for us to discuss.
Not at this time.
I have something that I want to bring this up, with the system that we have. We had all good here last year. You take that money and put it in food, leave it there. One way you go to nothing, still leave that there. Now, I'm looking at the statistics that we had there, our average age is 45.
Yeah.
And I don't think any of our retirees,
Oh, I asked a question on retirees with the,
They were, none of those
yeah,
five.
well, you know, I got a question for you there, Chris. It does not show a retiree category.
Right, we don't have it broken out that way.
We got
Okay.
we got two families.
So
Zero retirement.
I would want to confirm that none of those
What you're
are
thinking about was not one.
not retirees. I know we're showing them as active, but now if they were retired,
They be marked as retiring.
but it doesn't show your
No.
status
If there's one
down
that
here.
Tony thought was, it's not.
Yeah, I thought,
Okay.
that's what I just wrote.
I'm just saying, there's not a retiree,
There's not a
Code.
code down below.
you know. So I don't know, I would just want to confirm that.
I can confirm that.
Yeah, definitely. Retirees are included in the plan, yes. My question was, are any of our large claimants retirees? That was my
They're
question.
saying they were not.
No.
It says they're
No.
all active.
But what I'm saying is that one is a labor. You have
Yeah.
a retiree on a license.
Yes.
Oh, okay.
Yes.
But apparently, that person has not had a lot of claims.
No, they have. But your license
But
are not
not,
shown on that list.
right, but they haven't hit that threshold of our pocketbook claimants, but they've had claims.
Right, but they just haven't had a lot of claims, so they would be in the.
Well, that's not, well, we don't know that.
What we're talking about, there's been a lot of money this year in that place.
There's been Some, yes.
I know
Now, okay, I'm not sure what you're asking for sure. Now, ask that question.
what I'm basically saying here, I'm retired,
Yeah.
I have a lot of costs.
Okay, all right, okay, well, we don't know the answer to that question right here. Okay, the question that you need answered, and that we would need to answer, that you would need as a group is, how much of what percentage of my claims is coming from retirees?
So you're telling me on that page 4, the retirees aren't identified, they're all listed as, or, Page 5. right. If one of them was a retiree, you'd have an R outside or something, yes. Although I don't see that as
You can- you
an
can-
option down there.
You can run me a
That's not
report
bad.
that shows what total claims are being filed by retirees. That's what we need to know.
Well,
So what I'm asking, and they're on our insurance. That costs us a lot of money, but then to me, it looks like instead of getting independent insurance company, come in here and get your percent fee. Because if you're not say, you know, never here in the case, they're all other people.
Right.
But you're gonna look at say,
Yeah.
we're worried about it until they hit 65.
Right, we're worried about it for the 6, 7, 8, 9 years, we have to insure them, self-insured, and they could have $200,000 a year, get later, but you're having to pay that whole $200,000 a year.
The only way to really look at that is we just need to see what our total claims are from retirees, what the premium is for moving them off the plan, you know, I mean, it's
What
a,
their claims this year has no relevance to what their claims are gonna be next year. We have, first of all, we're not gonna today stop retiree coverage. No. We've got to address phasing it out or phasing that couple of things. And I don't think anybody here is ready to say, you leave this county, you got no more insurance, retire or otherwise. But we did identify the situation where we've got it where a young, long-term employee can retire at 50 years old, and we're hanging out there for 15 years.
They can go get another job, be working for somebody else, and stay on our insurance.
We did
We
not
have not
think
figured
that.
that. That's something else. I don't have any way of, I have no way of finding that out. When they leave here, I can't
Right.
track them and know where they went and where they
Yeah,
got.
I've got that same chart I gave y'all a year ago, where you can look and see how many people are gonna be affected by that, but the city, we continue to compare ourselves to the city's plan. Well, the city has, you've got to be at least, 58 years old to retire. We have got to set some minimum retirement age rules in this deal. And again, we don't have to start it today, now then we go from no limit to 58 overnight. We've got to phase it in over the next few years. If we don't start, we'll keep pushing this decision out.
Why have we got to phase it in? I don't understand that part.
Huh?
Why have we got to phase it in? I don't understand that.
Well, we don't have to. You can.
Well, you said we got to, I thought maybe there was a reason.
We have the option of
Okay.
going cold turkey and saying.
Well, I thought maybe there was
sorry,
a reason that we couldn't, we had to phase it in. I didn't know what you were saying.
I don't want to be in that meeting when that group shows up.
Well, we're talking about anybody that's 53, that's been here 30 years, and you're gonna say, okay, 58 is gonna be the cutoff. That's to me, it's not gonna take. Philip didn't deal with it.
No, Philip's been here long enough.
But I mean, he's 53, not 58. So he come in and do it called turkey, 58.
Yeah, okay.
They'll take it.
You don't have a problem with that.
just gotta work a little on it.
Chances are, who knows what's gonna happen.
Now, we can look, I don't have names on here, but you can look at a long list of people that are gonna be affected if you potentially go cold turkey like you're talking about. And you can whittle that down and phase it in, say,
Next year, it's 55 is the minimum retirement, then 56, then 57, and wherever your target is, but start something somewhere, and, eventually you end up where you need to be in a not too long period. But I would say that I personally think 60 years old is a reasonable minimum retirement age here.
What about if you don't make that, all of that decision, but if we go into, in effect, any new hire that you know before we're crossing that new hire, maybe that 60 is gonna be it? Can't you put in a new?
That would
if
be a
you don't
real,
do
that would be a real watered down way to do it, but you could do it that
I
way.
mean, you can still phase it
Everybody
out.
who's working here now.
But
is
if a
on
new
their-
hire, just say that new hire, okay, 60 is gonna be it, and grandfather these with the phase out or whatever.
And that is one way to do it, but somebody that's 35, I mean, things change all the time. As long as you're giving them some period of time. And I can understand not telling them that at 54, that all of a sudden we're gonna bump it up, although that does happen. That happens all the time. But somebody 30, 35, 40, 45 years old, I mean, that gives them plenty of time to, and I don't think people should, they may want to retire when they're 60, but let me tell you, there's very few people in this world that can afford to retire when they're 60.
Maybe I'll be working on 80.
I'm pretty much set over
Well,
right in there. I mean, it's just not.
How many and here's another thing, it's not only retirees, but their spouse, right? If they pay this way underpriced dependent care cost, so potentially you can double that, that liability every time you've got a retiree. And we know that the older a person is, the more likely they're gonna have high medical bills. So here's a list of people that, and the ages where they're going to be eligible to retire. You got a lot, well under 60-year-old people there. If you look at that middle column, age and eligibility, that particular person could retire from the county, starting there at the top at 52, 61, 60, 58, 51, 52, 49. And, some of those are many years away. The reason I put that years of service out there is to say, yeah, you may be telling a guy who's been here 5 years that we're changing the deal on you, but you don't feel as bad making a rule change to a guy.
Well, I mean, I'm here 17, and I'm not gonna get too strong over it, because I can take work on 20 years. So I mean,
Well, that's good, but in your case, your intentions are to work later in life. And we know that nobody's gonna probably retire at 50 or 55. Those aren't the ones I'm really worried about. It's the one that's gonna go, see ya, now I'm going to work for
Somebody else.
somebody else. But I really want to stay on your insurance, because it's really good.
Go somewhere else, get your car.
Well, they're gonna offer it to you, but
But me, the
why are
key
you
column,
gonna want to switch? Is their plan gonna be better than ours? I don't think so.
the key column on this is that years of service. And look at the people that you could potentially impact is that person with a lot of years of service, and now you're gonna change the rules on them. Well, somebody with 10 years of service, 15 years, 23 years, 21 years, 27 years, those are the folks that are gonna be upset if you go and change these rules. So that's why I give you that information before you go and just say, we're gonna, today, no more, you gotta be 58 or 60 years old. If you wanna do that, you can do that. I just want you to be aware of all the pitfalls and all of these decisions that you can make.
And maybe you could grandfather in if they've been here, 15 plus years or
That's
something like that.
exactly why I put this column. Where do you feel bad telling somebody the rules have changed when they've been here 10, 15? I was thinking 10 years was a pretty good cutoff. Well, then you look at the number of people that have over 10 years of service, then this list gets a lot shorter real quick.
How many years of service do you have to retire?
It's gonna be vested in 8 years.
Well, there's different rules. One is a rule for drawing retirement, and then there's a rule for this, for being on this insurance.
Yeah.
It's eight years on retirement. I think it's 8 years on this too.
Yes.
8 years plus, you have to be at least 60 years of age.
No.
Rule of 75.
Well, the rule of 75, the other day she told us it was also a rule of 60 and 80. I didn't know what they.
That's the retirement.
Whichever one they hit first.
Well, okay, well, they could be 68. And have 8 years of service, they're gonna hit that before, they're gonna hit 75.
They gonna get what now?
If
It could be
they
age of
work for
60.
us if they work for us 8 years and they turn 60, they're gonna meet that rule, or they're gonna meet the rule of 75.
They've got to work to 8 years.
Right.
But if
But they're
that's-
gonna get there before they're gonna get to the rule of 75.
I don't think that, I think the
I meant to
75 is,
ask her that yesterday, but that's what she had in her
That-
deal.
I think he,
I
If
didn't remember
you're-
that being, an option.
I didn't
I
think.
meant to ask her.
Big best. You can't right here, but I thought it was 12 years.
I've got the sheet in there.
Well, to get medical benefits, you have to meet the definition of retirement.
Right.
I don't remember mine. I don't
The
remember.
definition of retirement is either the 75 or the 60 plus 70.
We may need,
I think for this, they have to meet the rule of 75.
I
I think
this,
so, too.
I think
And
it's,
I'm not sure they don't have to do that on retirement, but that's not what her report says.
That always.
But,
If you hit-
Hey, that's been seen- that's been on there
It's
forever.
been there, that's always.
So on the retirement, you
but
can't get there. at 60.
it's an understanding
Or really at
that,
60.
that when you retire on that you'll be getting insurance. That's the way everybody understands it.
There's two separate.
Yes, there's two separate rules, one for retirement, one for this insurance.
People, whatever.
Well, if you end up, you can make this to where it was a 68, that's not what it is now. Now it's 40, there's once 49. They just meet the rule of 75, period.
And also, if you say you work in some other county 10 years, you come here and work.
Yeah, I mean, that would work on,
You can't get the insurance, you got to work here those years.
You gotta work,
I don't know if that's right or not, Mike.
yeah, you gotta work here so many years to get the insurance.
That's in the, that's,
Yeah.
Hey,
I think it's 8 years.
at one time we thought it was 12. We dug into the records and it was 8.
I know it's 8, because that's Fitch did it.
Must have been 12 in the news. Must have been 12 when we lowered it.
Oh, it's 8, the best part, yeah.
Well, okay, I put a check mark here on all the employees that are in this consideration list that have been here 10 years or more, whittled down to 19. In that group of 19, if you were to change the rules on them, these are the ages that they would be when they became eligible. 52, 60, 58, 51, 52, 49, 51, 55, 58, 53, 49, 54, 54, 49, 48, 48, 49, 49, 48. You've got 19 people there that could retire and be eligible for retirement insurance that are a long way from 65.
Well, that's just who's here now. If these people fall off and retire, you'll, if that's where you set your limits, that you're gonna have more coming on that are gonna meet those
Well,
requirements.
but if you establish a rule now where, you've got to be a minimum of 55, that will take care of all of your duties.
Okay, you're saying grandfather in those 19, and then separate.
All that grandfather. I'm saying that, you know, we prepare them now that, you know, next year, 2015, you've got to be 55 years old, minimum retirement, you know, minimum age to qualify for our insurance.
Okay.
And then the next year, you go to 56, then 57, and then top out wherever you want to be, whether that's 58 or 60. And you take care of this current group, and you take care of all new hires as part of that. But you've got to make a move this year.
Why do we have to have it, if we get, move it to that point, why can't we just move it to 65?
And eliminate any retirement insurance and retirement.
Basically, it would eliminate.
Right, because when they return to Medicare, they're not allowed to be able to get it.
Well, that's important discussion. In other words, just eliminate retirement insurance.
And that's a lot.
And you have that option.
And it's sort of like, you know, the idea that you had, that the insurance, you know, retirement, that you start being retired and take care of the people that's old, but they live by the county. That would happen.
The only thing I know for sure is that could be a costly deal.
It's funny that it hasn't been more costly thus far than it is, as liberal as this policy is. Right now, we've got, what, 5 retirees?
Saved, isn't it? 7.
That includes their dependents that are on it too?
9 plus individuals. Like, we've got a couple of spouses and one child.
So the total number that's on there is
9 retirees.
Retirees plus, you know,
We don't know how
like,
many
2, 3 spouses plus the child.
Yeah.
We have to.
but I'm saying the total number is 9.
No.
No,
9,
it's
11,
probably
12.
total, no more than 15, and that's pushing it.
Or 30. 12.
20 up to 15, we don't have any money.
So there's
Pretty good chunk to figure what
And one
you're
of
treating.
them-
80% of your government folks are retired. Well, I would propose that in 2015, at the start of the new year, January 1 of 15, we have a new minimum retirement age of 55, and increase that each year by 1 year. You stop at whatever you want to stop at, 60, 65, 58.
Well, I think you need to put that on the agenda. You can't get it on this Monday's agenda, but you need to put it on the next quarterly agenda in August, and I'll need to vote what you want to do.
Well,
I'm not gonna be for that.
You're not going to be moving it at all?
I'll be promoting it.
Okay.
What part are you not? I'm missing.
How old are you, Bill?
He doesn't want to exclude himself.
Well, it's not only myself, there's a few more too. Now, I'm gonna say this, I wasn't gonna say that, but I'll say this. When that happens, you're gonna have several of them leave.
We mean they're gonna leave.
They're gonna retire.
They're gonna retire.
But they're always
I
going to
came up with an exception for years. It's been a year since I thought about this. I think as part of that, those that have already met eligibility, I think they should be grandfathered in. Because we had that conversation a year ago. I forgot that part.
Yeah.
Well,
To make it fair, as of today, if you've already met, or as of January 1, if you have already met and you could retire right then and be eligible, you should be grandfathered in. And that would take
and we've
care
got
of it.
somebody that's under 54. But here's the other thing, if they qualify now, they're still gonna qualify every year because we're only moving it 1 year, every year.
No, well, he said 55.
Right.
I'm 53.
Right.
I'll be 54.
Yeah.
54 is still behind 55.
Yeah, I understand that, but if you use 54, for example, anybody that's eligible now that's at least 54 now is gonna still be covered up. It's gonna stay with it.
Well, I understand that, but I'm just saying,
Yeah.
you know,
How many people are already eligible if you want? Can't be very many.
I don't think they're on this list. I don't think this
Yeah, they have to be
is,
on.
no.
You just have to.
But I didn't see my social security number on there.
Yeah, there's Nick Brown's got on his one.
And it seems like we left you off of that list
Because you're
because you had already
It was
met.
me, Nikki.
And that's why you were on here. I told Carolyn, if they've already met the requirements,
I mean, I remember us talking about it, but
that's why you're not on here.
Yeah, but it
You're
could be-
satisfied now.
but it could be very many.
We don't want to take something away from somebody
it's
that's
already earned.
What'd you say, Carl?
Well, I think people want 3 or 4 of them.
Yeah, I think it is. Yeah.
It's more than 3 or 4.
Already, already.
What do you?
Yeah.
One, Tommy Buck.
Yeah, there's some of these other offices. that-
They can't
More
look.
than 3 or 4.
That would be part of that
But let me tell you, Tanya's over 54.
No, it wouldn't
That's
start
right.
at 19.
I have to go back and
I believe that
I just count everybody.
But yeah, Tanya, if he used 54, 55, or whatever, 55, yeah.
Deborah, she's 50.
So one or the other.
Yeah, if you're already over that number, then you're okay anyway. It'd just be the ones that were under, if you set the age of 55, it's only gonna be the ones that are under 55
That's
that
already
are already there. There's very
That's on
few.
this list.
Well, they're not being on this, they're on the full. But Tanya and those people are not, are over 55. Well, they're not your thing.
Well, I understand.
I'm just saying there's only a few that are under 55 that you would have to grandfather in.
Yeah.
Huh?
Terry and Deborah.
Terry under
I
55?
don't know how these around.
I know that Nick Brown's not on this
53.
list. The reason he's not on this list is I told Carolyn to leave off anybody that at the time she ran this list had already met the requirements.
Well, I was trying to get that count.
Now, before we vote, I can do this list one more time. If our objective is gonna be January 1, you gotta be 55 years old. So that we put at ease people like you and Nikki and say, don't worry, this rule doesn't affect you. You've already met the requirements that you were under the assumption that you would receive. It's only those that have met it, that are on this list.
Yeah, the reason you won't do that, because if you didn't, they'd retire on you anyway. You're gonna pay them, they'd retire before January 1st, if they can.
Well, it's not real, man, I'm gonna be a good deal for them.
Well, I mean, I'm not saying they're gonna retire, they'll retire and they'll go get a job somewhere else, so they would have that option.
And you have that option, still may not be a good option.
I would like to get this redo that again.
I will do that, but does that sound reasonable to y'all to stair step this starting the first of the year until we hit 60, 58, 65, whatever it is? And then I'll come up with some actual real life scenarios. Who's this gonna affect and who's it not gonna affect?
I don't mind the stair stepping. It's just, I've got to be at ease with it. As far as,
Well, have I put you at ease by telling you, you've already become eligible for retiree insurance, you have nothing to
or
worry
nothing
about.
to worry about it. Right, yeah. You will put several at ease like that.
The few people that are gonna be upset are the guy that's worked for
10 years and is 10 years away from retirement, and now you change the rules on him.
That's like when we had that discussion last year. I said, I didn't realize I was even going to be close to retirement or even have a retirement until I had worked here for 10 years. So, I mean, anything from 10 below, you know, I just,
Yeah, you're changing it on a person that, oh, well, you know, when I feel I'm looking forward to many years, but you don't want to change, oh, hey, I'm going to retire next year. And all of a sudden, you're yanking that off the table after I worked here for you for 25 years. That wouldn't be right.
They'd always sign up for Obamacare, can't they?
They can get on the website.
They don't have to get on the website. You just call us and we can sell your policies.
Yeah, that's
If you're
right.
applying for a subsidy, you go to the website.
You can handle that.
Yeah.
It's a fact of life. County jobs and city jobs didn't pay very good, but they had a good retirement, and good benefits. In my age group, there's a ton of people that work for that reason. So it would really be sad to do it that way, because it made good salaries. Now it's good salaries, but back then it was. And they worked just for that reason. It's good benefits, and good insurance, and good retirement. And, I agree, I'm like, we gotta do something. Like Carl said, not many of us can retire at 60. 55.
All right, well, let me just add, throw this, Al says he'd like to, you know, raise it on up to 65, will we get away with it? Will we phase it out over the next 10 years? What's your thoughts on that?
Start at 55 to 65.
But ultimately top out where you eliminate retiree insurance.
Take 11, you can take 11.
Take 11 years, yeah.
Well, I understand that's a policy that y'all can put in place. That's a policy you could put in place in 6 years from now, when y'all, when somebody different vote, they can change it. Or you got to be, I mean, nothing you're gonna do. To prevent somebody down the line from doing something different, but that could be the plan that you put in place.
What other topics were there?
Well, the only other thing to talk about was something Steve mentioned earlier, is even after you determine who you're gonna provide retirement insurance to, you have the option of taking them out of this plan and buying a plan, so you have your costs fixed. You've got to try to get the plan to match as close as you can to what they've got, because we don't, the intention's not to cut their.
Which I can tell you on the individual market, your deductible choices are 0, $250, and it jumps to $1,000.
We know what the cost was then, though.
Yes.
And I can tell you exactly what it costs is, for a 55-year-old up, it's a ton.
Well, it is.
Well, it may be less than 200.
Well, I mean, you have to compare that, I mean, it's just a numbers deal. I mean, you look and see what your actual claims cost has been and compare that to what the premium would be, and that helps you make a decision. That helps you make a decision.
That's a second decision that can be made
Sure.
in a couple of months, and y'all can get us some figures to look at.
We can run you, I could get it today. I had a group that was debating whether to drop the health insurance, and the guy making the decision was 62, and his cost was $1,300 a month to cover himself. Exactly. And that's why, well, that's $750 deductible, his premium.
No, they're funding $750 per
Oh,
week,
okay, and what your funds fund is, yeah.
which is, for some of those would be
You
under.
know you're gonna pay more, but what you've done is you've eliminated that upside potential that you could.
And the unknown. Exactly. But what I'm telling you is you cannot compare it to a $750 deductible, because at this point, there is none.
Right, well, we have to go to 1,000, but can y'all get us figures on our retirees, not names?
Yeah.
Just numbers of what our plans
Sure.
are retiring, because apparently they're not broken out here anywhere.
That's correct.
So we need to know.
Sure, I mean,
we need to
you
see
gotta have
that,
that.
even though that doesn't
Right.
necessarily tell you that's what it'll be for next year or the next year. because the claims can be totally different, but it gives you a history to look at, so you can compare that to what the premium costs.
Well, are we here today to give you guidance on what to start shopping for? Or are we gonna have another fall meeting here? Because we've got several other topics to discuss, co-pays.
Yeah.
Deductibles and.
Maximum
And spouse insurance, if they have another policy available to them, that was another topic.
You know, as far as benefit design goes, I would probably suggest you kind of let us give you some choices there and, you know, estimated cost of how much it's going to reduce the expenses in the plan. You know, like going from $750 to $1,000 deductible, you know, what's our estimated, you know, reduction in overall expense and those kind of things. And then when we meet next time, you know, maybe we do that in September. You know,
In October.
probably need
The stop loss is targeted to that. I have your UMR administrator for September.
Which that won't really matter.
No, it's just under a third-year fee.
Yeah. So, you know, come up with you know, 4 or 5, you know, minor benefit changes and see what that's going to do cost-wise. You know,
We used to try to hold those early in October, is that too late? That gets us past all these tax budget.
yeah, we, you know, if you like to do it first week of October or something like that, or, you know,
Because
that's
the
probably
plan
okay.
actually changes.
Of course, we still,
Perfect,
yeah,
right?
it'd be better if it was September, but the deal is, I don't think, you know, I don't think from what we've talked about in the past that you're talking about wanting to make any drastic changes. So it's not going to be, I mean, the things that I would be bringing to you, that I would probably suggest, and Chris might have some other stuff, but maybe, you know, going from $750 to $1,000, get a $25 office copay, pay going to $30, or, you know, or maybe adding a specialist copay of $50, or, you know, something along those lines.
And the other thing is decide what we're going to do about the spouse. Because right now we're treating the spouse no differently than a child as far as what they pay. And
Yeah, you're
it's
fine.
real hard for us to be able to track whether that spouse has insurance,
Other
whether they
coverage.
work somewhere, whether they have the opportunity for insurance.
Right.
Are you familiar with what the city pays their insurance?
I didn't get it this year, but I've got it before. Have you got
I
it?
don't think they pay into the spouse, do they?
No, they don't pay anything. They pay, I've got the rate.
Have you got what the deductible and stuff is now? I usually call right to get
Look
it.
across Blue Hill, I've got it's who they use and,
What is their deductible?
While he's looking for that, what about topics that I learned about at the health first seminar that incentivize people to have annual physicals and incentivize people to take their medicine that they're prescribed?
And that's kind of what I was talking about before, the 2 groups I was telling you about, that hand in hand do that. The one large group in Paris is checking every quarter how many people have done their preventive visit, and we can run a report of that and know. And then they actually are giving a prize to those people. This year it's a prize, next year it's a requirement. And if
I'm
they
ready to start.
and if they don't do that this year, then next year their premium goes up.
Now, are they
Self-funded.
government type things?
No.
I don't know what to do with the prize deal.
Oh,
What we
okay.
may have to do is charge them more of a premium.
Then just jump into it. I have another
Or
group.
you send them a warning letter and say,
If you don't get this done next year,
2015 is a pass. But remember, the rules change, and if you fail to do this.
And that's what they're using this year
we're going to
to
charge you a premium.
kind of warm up to it. And you would probably start that in January, saying, you know, we're going to strongly suggest you do this. If you don't start this year, then next year your rate goes up.
Right,
I mean,
or probably where we pay for all the employees 100% now. If they don't get that done, they got to start paying $10 a
I was gonna
month or
say-
something on there. There is a cost for them to not get that done.
I mean, y'all are playing with Heritage Bank. That's what they do with their, so you can talk to somebody, Kathy or somebody over there, because they do that. If you don't do it, They're gonna increase your premium.
Because that's the only way if you know somebody's a ticking time bomb. But again, it goes hand in hand phasing it in. You sign it, you log in and you create a user password to get into the UMR website. Then you do the online health assessment. And then the next step is the preventive visit, the actual go to the doctor and the preventive visit. And it's a stepping stone. But you can do all three of those things this next year and say, this is what you're requiring. This is pretty easy.
Giving you warning.
Give them warning.
Giving you years warning. We're not asking you to step on the scale and get you way over this much and pay more money. We're just saying we want you to do the smart thing. Go get a checkup so that we can be sure you're getting treated for anything that you don't know about.
Go on, no, I kind of got that warning letter from Humana on my membership. And they didn't say anything about charging more, but they could they?
Well, they will.
They will.
They're not saying it in your letter, but my parents got the same one, and I said, call your broker, because I said, the second part of that is, if you don't comply, you're getting a rate hike. She did, and they converted it.
So what have you got, city assumption?
They employ is $394 a month, and that'd be $47.32 a year only.
But the city pays not,
Yeah.
the city pays all of the employees for it.
And then $1033.26 a month, which is $1,200, it's $12,900, but it's less $3,833. It'd be $8,565. Dependent coverage costs $638.89. So you got 1 or 19.
That's what the employees cost.
No, dependent.
Yeah, but who pays that? The employee pays that, or does the city pay any part of the dependent coverage?
City pays half. They pay $319.
Okay.
The employee pays $319.
Okay. So that's what
$638. That's.
I was pretty close to that.
no, ours is 100, ours is 280.
Well, no, we have tiers of 5 dependents.
Right. If you have just one dependent, it's 280 for us, that's what we charge. And then we add a little bit for each one, so if you got 5 dependents, but we don't differentiate between children and wives. Spouse.
This said 1 or 15.
Yeah.
Whatever, I guess.
So we're pretty close to most numbers. We're at 280.
What's the-
390.
What's their deductible?
Yeah, plans in.
Deductible is for 30.
That's the office copay.
And urgent care is 55, outpatient is 100.
Probably 1,500 if I remember. Is it 1,500 that deductible?
That's their co-pays. How much will the employee have to bear dollar-wise?
Be at the top. Look at the top. Individual deductible.
And the
You want me to see?
maximum amount of pocket you need to let the both of them.
Let me take a quick look at it.
And 1,500 individual,
There,
45.
there you go.
Yeah,
Three-
that's, I was thinking it was
3,000.
1,500.
Okay, so
1,500.
4,500 family.
That's what our out-of-pocket.
What's your out-of-network, what's your out-of-network deductible? Because I bet you it is 3,000 out-of-network.
They don't have it. They just all the same. And now they work, you won't pay us 100%.
Ours is
It's 80/20.
280 and theirs is 319.
Okay, they still have an old plan, RN17, that's combined in and out of network deductible on that 1,500 to 45 family, that's what's gonna change, that's the next renewal.
All right.
$30 office copay, their out of pocket, their in-network out of pocket is 4,000 on individual, 12 on family. Their out of network is 8 and 24. Now that will also
Never
change a
change.
little bit.
That was down.
Yeah, after the ACH.
But co-insurance is the biggest thing that's different. Y'all's co-insurance is 90%, theirs is 75. Wow. And that's a big, huge chunk. Yes, it is.
Well, it doesn't really, correct me if I'm wrong, but it doesn't matter what that is if the maximum
It's 4,000.
that you're gonna be out of deal is so much.
Yeah, but still, that's just,
But you just get there faster.
Yeah, you just get there.
Right.
that's right.
Yes.
Right.
Well, I think, I don't know that you want to go all the way to those numbers, but you obviously need to move, we need to move some of those numbers.
And their drug card is 40/40/60, which this is just a stock plan. I mean, RS-17 is a plan that's been running forever, and that will change every year. No, it's short for me.
Do you want to look at your calendars on there that first week of October and see what percentage we have?
And that will be, will you have the renewal? And you want us to have the renewal at that point, with the options at that point?
We can make decisions that.
Well, but you saying we'll have to, you can't get it before mid-October. Let me go back and check.
Well, but won't you need them to tell you what they want these to do?
We were already gonna probably give them a couple of variables, but we can look at that one for sure.
Friday the 3rd.
You know, if we could get you something, well before that meeting time, that would just say, hey, here's what we would propose, here's percentage-wise, according to overall book of business, what we would expect going from a 750 to 1,000, would, you know, how that would affect your rates, you know, or affects your claims. Okay, that's really what you're doing, you're affecting your claims.
Right.
And we can get that to you before the meeting day, so y'all can kind of be kicking that around a little bit.
Obviously, I mean, we'll benefit by whatever you raise the maximum amount of pocket by, because that just means that has to be paid for, it comes out of the claims. Same thing by raising the deductible, that's take those numbers. On the actual, what we charge the employees for the dependent coverage, we're not very far off from what the city is. In fact, in some cases, we're higher than them, because they have somebody that has 3 or 4 kids, they're still just paying $319, and ours are paying more than that.
That month, they're paying like $521 a month. We've got anything you want to do.
So,
But again, there's something, I mean, they're fully insured, and I just bet you that their dependent costs are gonna go up this next year, because the way the funding is working is you're paying for now individual children. You're paying for up to 3, and there's even the large group, they're factoring that into the rate. So their renewal is what, just January as well?
I don't know what they're.
I think
Or
they're
October.
September.
So they're, so you're looking at October the 3rd?
Yeah, yeah, probably is, yeah.
October the 3rd, you think we could have, if we give you variables by then?
Can you get us, we'll talk about some just benefit changes, and then we can get with your claims folks and get us some kind of percentage or the stop loss carrier. We just kind of run the stop loss carrier, run it by them and say, hey, you know, or if we make these changes, what kind of number are we talking about, you know? Because, you know, when you make benefit changes, it'll affect your stop loss premium a little bit. Okay, but it will also affect, really what it primarily affects is your aggregate stop loss number. You know, it'll bring that number down a little bit, so. But it all boils down to, just, you know, how much money's coming out of your checkbook to pay for claims is what it amounts to, so. We can give an estimate on that percentage.
Do we have a time in mind, October 3rd?
The only other area that Brian had mentioned that I need to look at would be the spouses. I don't know, how do the other people you insure handle the spouse that works somewhere else that stays on our insurance? Because
It varies depending on who you're talking about, but we have a lot of,
I don't know how you track that.
well, you have to send something out once a year, basically.
But if they
They can lie about it.
They sign a deal,
They-
because I agree to notify the county if
Yeah.
so my spouse goes to work and understand that
you know, but you can
But
say
there's no way to
if,
check it. I mean, I don't know any way to check it.
not really, other
It's an
than,
honor system deal.
The one way I look at that is, we give them the option that if their spouse is working somewhere else, they can change over to their insurance. They don't have to stay on ours. So why should we put a limit on them, on their spouse? I understand. Okay. We let, a couple of years ago, we let some of the employees get on their spouse's insurance instead of taking this insurance.
Well, those were two military situations where they actually had better insurance.
Well, that's still, there's some that have said,
Here's the
had
only
the same
thing,
option.
here's the only thing I'd say about that, Philip, and I understand what you're saying, but what's different is their plan may be a Blue Cross Blue Shield plan. Our plan, you could be costing the county $200,000 by letting.
But what I'm saying, what I'm really getting at is, why should we distinguish this is right and this is wrong?
Well, maybe you shouldn't, I'm just telling you that you're.
I'm just throwing it out there.
You're putting
The
it.
answer
That's the way I feel. Well, I understand that, but they're going to look at it and say, well, they can do this, but why can't we do this?
If both plans are different, then.
Well, as,
Yeah, but we have one, never mind, she's back on, she's on.
If we were both on Blue Cross Blue Shield policies, we know what our cost is by letting them back in here. We don't know what our cost is, you're self-insured. Nobody does.
Well, a year ago, I sent out that memo to the department head saying, hey, if anybody would have a problem with this, let me know. Well, I got about 4 or 5 letters from people that are going to have a dramatic impact to their family financial situation if their spouse is kicked off our policy and forced to go to somebody else. I'm just saying, be prepared. You're going to have some hostile folks when that happens.
Usually it is the same way, grandma, they're all here, you do.
Yeah.
Yeah, you can cushion the blows on one side by doing that. I guess, I don't know how much flexibility we've got doing something like this.
Government hasn't regulated that one yet.
and you know, Charlie, you also have the option of changing your spouse rate.
Well, that's what, I
You
mean, you
know,
can change the spouse.
ordinarily, the spouse rate is much
And
higher
I
than
have,
the child
that's
living
right,
rate.
that's right. I have seen that, and the ones I looked at, they didn't, all the dependents weren't the same. The spouse was different, but I don't know if that's just any spouse or a spouse that works. I don't know. There's a
You can go back
differentiating
to the
option.
traditional 4-tier rate structure, which would be a little bit more
A little more equitable.
true to what the cost really is for a spouse, and you could have, you know, children and a whole family. Because right now, I mean,
Spouses tend to cost more money than children.
yes.
Let me say something. You know, you sit here and you talk about, oh, we can go on this, we can go on that, we can do this, we can do that. So, these people sitting out here, we're fixing to go up on stuff hard, we're gonna look at all of them on stuff. They're not getting any more money, so
I understand.
there's gonna be more money out of their pocket.
Well, you can still control the rate. What I'm saying is have the rate be a little bit easier to understand, because a lot of people don't understand this rate structure when you're dealing with some of your folks. But they know that if it's an employee, if they're adding their spouse, this is what their spouse's rate is. If they're adding all their kids up to 15, then that's what their kids are gonna pay. Or you could go, you know, you could change it to where the number of children you're insuring.
My thing is, I just don't want to go up there and start saying, well, we're gonna go this. And the things, yeah, it's real hard.
You might go on some of them, you might go on the deductibles, some of that stuff.
Look at it, right, look at this, but,
You might want to get the reinsurance issue recommended funding to see what they would suggest you charge.
Yeah, we can get recommended funding, and something else you probably ought to consider. I mean, when's the last time you increased the amount you're putting in per employee into the claims fund?
It's only been a couple of years. I left it flat the last 2 years.
Yeah.
Plan on leaving it flat again this year.
Okay,
because it
because you
looks
got a
like
surplus, yeah, I mean, you know, so, but anyway, that's something that you need to at least think about.
I did raise it several years in a row.
Yeah,
And then the other thing I did is, we do that much per employee, that the county puts in. And then for a while there, on top of that, we put another 125,000 in. And then one of our really bad years, we just had to come in and budget to make another, we put another extra 250 in. Maybe the first year you were here, Brian, was that?
They can also do different cover rates too.
So,
We get five,
Yeah, right.
it all came from general county, but
Sure.
part of it was identified per employee.
Sure.
The rest of it was just
Yeah,
transferred from
right.
general fund,
Yeah, so,
cover the short.
right, sure. Thank goodness you had it.
That's right, thank goodness we had.
Right, well, we know what topics we were discussing, I'll put this all on the third, 9 o'clock, Friday morning. Okay.
Add that on your list. What I just said was you could actually have different cover rates than these rates.
Well, we had different cover.
You do? What are
Yeah,
you?
they're 750, aren't they?
Yeah, they
A
paid the
little bit
750.
more, not much.
Well, they paid the part that the county's putting in.
No, we're not going to, we're not going to touch them.
They pay every, if they're on cover, they pay the full.
They pay the full
They
750.
pay more than that. They pay.
750 plus 2%.
They pay a big number.
Cover rates.
Well, this is our one sheet. Our one sheet. It's pretty high. It's pretty high. They don't understand what they call it.
Oh, okay, well, then that's good.
So that's all we don't have to pay.
They don't stay on that.
Okay.
We never had but one, I don't think it got on.
I might have one or two. Yeah.
They didn't stay on the phone.
They can't afford to stay on the phone.
All right, anything else?
So you're gonna put on the agenda for 2 weeks, and talk about retirees insurance. And then we're gonna do this part in October as far as co-pays, deductibles, maximum out of pocket.
Well, we'll try to get that to you before then too, so y'all can kind of be looking at that, so it's not a,
Motion by Commissioner Fields, adjourn.
Second.